I think, sorry, I was reading from this book. I think the organizers have given me a latest one, so probably the chairperson also knew, and the speakers also, probably some change in a speaker, this thing. So the first speaker is Sakir Ahmed, Bhubaneswar. So can I call him? He will speak on the best of ACR, basic and transitional. Dr. Sakir? Yeah, he's there.
Thank you, sir. My thanks to the IRA for inviting me to speak on this very relevant session. Why relevant I'll be talking of. These are my disclosures, and I'm thankful to the IRA for giving me this IRA travel grant to go to the ACR. And if I can have control, the opening session of ACR started with a keynote address from Dr. Abraham Varghese, and he told us a few stories. One of the stories was of Gilgamesh, one of the oldest written down stories. Then was the story of Beowulf, one of his favorite movies, Jaws, and the story of COVID. What these stories have in common was that there was conflict, there was crisis, and out of those extraordinary circumstances, someone ordinary became a hero. And what I feel, what is important in a story, it needs to be retold. So let us look at the most important stories, according to my opinion, from the ACR. So each has said something. I'm neither innocent nor am I beautiful, but time here is my enemy. The 50 hours of talk at ACR, I'll have to summarize within 15 minutes, and this is basic, so it is difficult. I would ask you to please bear with me as I go through at a faster speed. So the first day was all about somatic mutations. So what is a somatic mutation? Anything which a mutation in the germline is carried across generations. But a somatic mutation occurs in only one cell type, say a monocyte or just a myocyte or a neuron. And the classical example we know of is a cancer. We did not know any mutations, somatic mutations, which would cause disease except cancer. However, things changed when this article was published 2 years ago in the NEJM. In 25 people with a median age of around 60 years, they describe a Vexus syndrome. And this was because there was a somatic mutation in one enzyme, UBA1, in only the monocytes. All other cells were normal. And the clinical presentation was different. Someone had presented with rheumatoid arthritis, someone with relapsing chondritis, someone with GCA, someone with PEN. Most of them have some amount of thrombosis or macrocytic anemia. But the underlying somatic mutation was same. And inspired by this publication in NEJM, different groups have looked at it. CAPS, or cryopyrin-associated periodic fever. If we do a sequencing, 58% of them we do not get the expected mutation. But now it has been shown that 20% actually have a somatic mutation. Similarly, people have worked in Sjogren's syndrome, and they have found a histone demethylase, which is somatically mutated only in certain lymphocytes. All our patients with rheumatoid arthritis have rheumatoid factor, but only few develop mixed cryoglobulinemia. Why? Because there is some somatic mutation in the B cell which makes the rheumatoid factor insoluble, precipitates, and causes all the manifestations. Even Erdheim-Chester disease has been shown to be a type of disease caused by somatic mutation. The hematologists commonly talk about clonal hematopoiesis of indeterminate origin. So these are certain lymphocytes which have accumulated certain somatic mutations. And since no one knows what they are actually doing, they have been called indeterminate potential. They are most commonly found in memory B cells, and we don't know why. There are specific genes which are mutated in these lymphocytes. And whoever has this chip, the cardiovascular mortality doubles, and they have a 10 times risk of developing hematological malignancy. The second part we understand, but first part, why the cardiovascular complications increase, we do not. The neurologists took the upper hand, and they have shown that people who have chip, they have a 10% chance more of developing stroke. And this is going to be the future, I believe. People are going to look at somatic mutation across diseases, and we may have to change our definition of certain diseases. The second part, I'll focus on precision medicine. This article was published in NEJM again 2 years ago, where they took a spot of blood and they found specific cells called prime cells which can predict a flare. If prime cells are found in peripheral bloods, within 1 week the person is going to have a flare of arthritis. What they did with this data, the same data, they tried to find out the oral microbiome. They have taken the finger prick blood and computationally they have tried to find out what is the bacteria present in different parts of the oral mucosa. And they have found that antibodies are there in patient serums which are also attacking whatever microbiota are there, and these are citrullinated peptides. So this, what was done for detecting a flare in precision medicine is again showing collaboration for microbiota in rheumatoid arthritis. Again, another study of precision medicine, they have taken synovial tissue and they have looked at all clinical parameters, tender joint count, CRP, ESR, and the entire transcriptome of the synovial, single cells they have taken, and they have shown that there are basically 3 pathotypes: lymphomyeloid, diffuse myeloid, paucifibroid. And when they have done the further analysis, they have found that some of these pathways will predict, some of the cells present here will predict the response after 1 year. Just for an example, specific B4 plasmablasts, if they are present, then there is a high risk of radiological progression. Then if PD1 positive peripheral helper cells are there, then they have a high chance of achieving remission. Coming to lupus, even in patients without any proteinuria, if you do a biopsy, they may have activity. And those who have activity on the biopsy without proteinuria, ultimately they flare and have a clinical lupus nephritis. So how to detect this? Again, they have done urinary proteomics, transcriptomics, and they have isolated a signature. So from the urine, you can look at the collection of these biomarkers and predict that this patient is having lupus nephritis, and they can go one step ahead and say he has definite proliferative or she has proliferative nephritis. And they have compared the specific markers and they found change in CD206 and change in CD136 to be much better predictor of outcomes at 1 year as compared to urinary protein creatinine ratio. Those were the studies of translational medicine, the precision medicine. Coming to newer targets or novel targets. In giant cell arthritis, they have done the work from the basic to the patients. First, they have demonstrated that GM-CSF is overexpressed in the biopsies of arteries with GCA. They have done animal studies, which I have not shown here, and they have even done a phase 2 clinical trial in patients where they have given an antibody against GM-CSF and showed that the flare rate reduces. So this is one potential area in GCA. Another potential area, you might all have heard of CAR T cells, and there is a longer CAAR or chimeric autoantigen receptor T cells. To make the terminology easier to understand, they have called this chimeric autoantigen T cell receptor. Suppose in antiphospholipid syndrome, we know what is the antigen. So that is the B2GP1 glycoprotein. Suppose the B cells which have antibodies against this can be eliminated, then the disease may go into remission. So this was a proof of concept study where they have made T cells which carry beta-2 microglobulin, beta-2 glycoprotein. And when this is expressed, all the autoreactive B cells will get eliminated. In the animal experiment, they have shown, so this is the control and this is the mice having the antiphospholipid antibodies. Here we can see there is depletion of the antibodies, depletion of the B cells which carry pathogenic antibodies, while the normal B cells are still there. Then the next concept I pick up is of immunoaging. So there are 9 hallmarks described for aging, but what was felt missing was that there is an inflammatory component in aging. So what they have done in the 1000 Immunes project, they have collected multi-omics data from 1000 patients, genomic, metabolomics, epigenetics, everything they have collected together, and they have tried using machine language to determine what is, how to predict immune aging. the machine learning has shown that inflammasome genes have a common causality with hypertension, arterial stiffness, and longevity. Using this model further, they made a eye age or inflammatory age. That is, the machine learning will take all the parameters and give you one value. And this predicts left ventricular stiffening, arterial stiffening, as well as it predicts the outcome. They have taken the Framingham cohort data and they have shown that persons who have a higher eye age and everything else is matched, there is a higher cardiovascular mortality. So, in our patients, this is very important because they have chronic inflammation. Coming to next concept, that is a concept of pathogenesis. This paper has come out last year where people with fibromyalgia, their antibodies were taken out and given to mice, and the mice developed fibromyalgia. You might have been aware of this paper. They did all kinds of experiments to show that actually mice had fibromyalgia. Then they took the skin biopsy. We can see small fiber neuropathy is there, what is described in fibromyalgia. And then they saw that these human antibodies from fibromyalgia patients were going and attaching to the dorsal root ganglion, which is a gatekeeper for pain. This is a histology, and between the neuronal cells we can see the satellite cells, and these satellite cells are being tagged by these antibodies. And even in patients who have long COVID, pain after COVID, they have shown similar antibodies are present. So is fibromyalgia an autoimmune disease? It is too early to say, but one potential, this is another study presented at ACR where they have shown that IL-1 receptor may be responsible, and that IL-1 receptor is there, what I have shown previously, in these satellite cells. And they have taken a mouse model, they have given the mouse IL-1, and independent of the swelling caused by IL-1, the pain is more if you give them IL-beta as compared to controls. Then for lupus, they have shown if a TLR7 has a gain of function mutation, it can cause lupus. First they found out in one girl, Mexican girl, 7 years, then they found in 2 more families. Here the mutation is being shown, and they validated in a mouse model where they mutated the same gene, and the mouse also developed glomerulonephritis and raised dsDNA, Smith antigen, etc. So since time is there, I'll just talk about food at the ACR. There was one study which looked at ginger. Gingerol, when you give to the in vitro, this is not in vivo study, the netosis comes down. I'll not go into details. Then again other food related, butyric acid, which we get from butter, they showed if you treat the dendritic cells with butyric acid, they become less active. Actin polymerization doesn't occur. Maybe they eat too much butter and they are too slow to move, but they will not go and go to the antigen presenting cells. Then this is the Western blotting, and this is how they are proposing. I do not have the time to go into details. And then the immune aging study, they also showed that people who were taking caffeine, they had lower eye age. The inflammatory age was less in people having caffeine. And they again validated this with some animal experiments. They fed the mice, not animal experiments, they gave the caffeine on human monocytes, and they showed all the inflammation associated genes were coming down. To summarize, what I feel, somatic mutations is going to be a game changer in the next decade. We may have to reimagine medicine, because our diagnosis is now all phenotype based, but this may change our diagnosis to some more of a lab based. Precision medicine was a dream 5 years back. Now it is gradually gaining acceptance and is likely to come to the clinic very soon. And as I said, the distinction between diseases is blurred. As we saw in vexus, vexus can present just as rheumatoid arthritis, or it can present as polyarthritis nodosa. But word of caution here, whatever has been shown, it is not necessary that everything will work. They may work. If you think everything works, then from today you should put ginger and butter in your coffee and have 1 cup every day. sir.
Thanks, Saket. Thanks. Excellent. You can join here for later on question answer. You can join. The next speaker in this session is Dr. Sarachand Mauli from Hyderabad. He'll be talking on advances in rheumatology, top 10 clinical pulse from ACR.
It's fine. Good evening, everyone. Couple of days ago, Dr. Danda asked me to some of the clinical part of the basic one is covered by Dr. Sakir. So I'm going to cover the clinical part. Of course, I will be biased because I can cover only what sessions I have attended. Next slide. Next slide. Next slide. Previous slide. Next. Dr. Amrita Gopal is our PG. She presented one of her cases in Thieves Market. Next slide. Dr. Ramya presented her case in Global Expert Meet in Idiopathic Inflammatory Myositis. Next slide. Next slide. Next slide. Next. So I'm going to touch upon a few sessions which I have attended. Is one of the, sorry, it's not coming on the laptop. I have to see there and talk. This is from the review course, Sjogren's disease and mimics by Sarah McCoy. Regarding Sjogren's syndrome, next slide. She said 3 important points. Rule of 3, duration of dryness 3 months, Zika symptoms of 3 months, and teardrops using more than 3 times. And most important thing she mentioned is the swollen salivary glands with a specificity of 98%. Next. And in the aqueous layer, we have 3 layers. Sjogren's affects mucin and aqueous layers, whereas blepharitis affects lipid layer, including the topical retinoid use also can affect the lipid layer, causing Zika symptoms in the eyes. Next. Dr. Sanjay this morning mentioned, we ask for Zika symptoms in the mouth, but actually we don't measure. But the easiest way of measuring it is collect the saliva in the glass and measure the weight. 1 gram is equal to 1 ml. So if in 5 minutes time, if it's less than 0.5 ml, it confirms Zika. Next slide. Next. Regarding focus scores, we have to see if there are more than 50 lymphocytes in 1 cubic millimeter, that confirms the 1 focus score. Next slide. Next slide. The differential diagnosis when you suspect Sjogren's is sarcoid, amyloid, hemochromatosis, IgG4 related disease, and lymphoma. Next. Next slide. There are some of the things we may not look into when we see the Sjogren's. So she mentioned use of contact lenses, LASIK operation, infections like hepatitis C, HIV, and sarcoids, metabolic syndromes like diabetes and use of drugs, rarely Parkinson's. Next slide. And hepatitis can be one of the differential in Sjogren's. So it can mimic Sjogren's. How to differentiate is SSA would be negative and CD8 predominant lymphocytes and submaximal lymph nodes mostly involved rather than parotid. Next. In HIV, SSA would be negative, CD8 predominance. Next. If it is sarcoid, SSA would be negative. You would see on histology non-caseating granulomas. Next slide. Next slide. These are new proposed guidelines, recommendations by ACR is going to come up for APS diagnosis. Here they have stratified the risks. For example, if there is a venous thromboembolism with risk profile is 1, without risk profile 3. If it is arterial thrombosis with risk profile 2 score, without risk profile score 4. Lupus anticoagulant 1 time 0.1, persistent positive 5 score. Anticoagulopin antibody IgGM only, interestingly score 1. IgG or IgM positive, moderate positive 4, high positive 5. If IgG or IgM both are positive, high positivity score of 7. To classify APS, we should have at least 3 points in each category. That confirms the diagnosis of APS. Next. And this has got high specificity and sensitivity, you can see here. Next. Here in review by Carol Langford from Cleveland Clinic. Next slide. This is Gloria trial, randomized double-blind placebo-controlled trial that examined the benefit and harm of prednisolone 5 milligrams a day, given for 2 years, added to standard care in patients age 65 and above in active RA. Next slide. So it showed the lower disease activity, reduction in the joint score, but trade-off of 24% increase in the adverse events. Next slide. Oral surveillance study where they have used in rheumatoid, they have used 3 arms, tofacitinib, 5 milligrams, 10 milligrams with anti-TNF as a third arm. Next slide. So here what they have identified is the risk of mass and cancers higher in tofacitinib group. Next slide. Next slide. Next slide. History of FDA approved Janus kinase inhibitors in rheumatology up till recently. Tofacitinib approved for RA, psoriatic arthritis, polyarticular JAA, and recently ankylosing spondylitis. Baricitinib in rheumatoid arthritis, upadacitinib in RA, psoriatic arthritis, ankylosing spondylitis, and non-radiographic axial SPA. And deucravacitinib in psoriasis. Next slide. Next slide. Next slide. This was covered by, I think, Dr. Rajeshwari yesterday. Next slide. IVIG in dermatomyositis. Next slide. It has met the primary endpoints. So as per this, FDA recently approved for dermatomyositis. It's the first approved agent for any inflammatory myopathy. Next slide. Anti-CD19 CAR-T cell therapy in refractory SLE. Next slide. They've tried in 5 patients drug-resistant SLE with SLEDAI score of more than 16. Within 3 months, you can see SLEDAI score 0 and complement levels become normal and dsDNA become negative. Next slide. Next slide. Rheumatology secrets. There is one session on rheumatology pearls and secrets. Jason Kofrenberg, he is the co-author for Secrets textbook. He said whenever you see any case of recurrent uveitis and think of ankylosing spondylitis, he said in his series around 40% of the patients with recurrent anti-uveitis turned out to be having ankylosing spondylitis or some form of spondyloarthritis. Next slide. Next slide. If we don't give maintenance therapy in ANCA-associated vasculitis, in 4.5 years, the chance of relapse is around 25%. Next slide. Next slide. So he says we have to go at least 5 years of maintenance therapy in ANCA-associated vasculitis. Next slide. Next slide. Whenever we see a case of lupus, there is a 30% chance of having APS. So always do APS workup in the beginning. Next slide. And he says, always think of whenever you see exacerbation of skin lesions, think of drug-induced also, like NSAIDs, PPIs, other drugs like ACE inhibitors. Recently, I've seen one case of PPI-induced exacerbation of skin lesions. When we stopped the PPI, the skin lesions improved without increasing the steroid dose. Whenever you see a swollen eye in the rheumatology clinic, think of these differentials like GPA, sarcoid, IgG4 disease, rarely lymphoma. Recently, we confirmed a case of VEXAS in our clinic. Next, in the same session, Dr. Johnstone, he talked about myths and facts in rheumatology. Myth here is symmetrical polyarthritis. We always think of rheumatoid, but he said rarely they can present with oligoarthritis or next slide, migratory inflammatory arthritis. Next slide. Here he mentioned interestingly, GPR MPA can rarely present oligoarthritis. I have a couple of cases in my clinic because initially GPA MPA can present the polyarthritis with false positive rheumatoid factor. So always we have to keep that in our mind. Next slide. Another myth, RA improves dramatically in pregnancy. He says there is only 20% people going to remission in pregnancy. Flares may happen up to 29% because we may reduce the DMARDs or stop some of the DMARDs. And postpartum flares may happen up to 47% of rheumatoid pregnancies. Next slide. Pearl GPA patients can have submandibular gland enlargement. Here the differential would be Sjogren's, sarcoid, IgG4 disease, and the GPA. Next slide. GPA and IgG4 exactly they can mimic each other. Then how to differentiate? Next. The histology may look similar. Next. Next. So GPA, you expect granulomatous inflammation, necrosis, and neutrophil inflammation. Next slide. And here, ANCA will help us to differentiate GPA from IgG4. Next. Next. In this session, cancer screening recommendation for inflammatory myositis, Alexander Allroyd from Manchester. Next slide. He says, whenever you deal with adult myositis, inflammatory myositis, there is 1 in 4 chance of developing malignancy. And according to his analysis, it's a high risk with dermatomyositis, anti-TIF, NXP2, age more than 40, high disease activity at the time of diagnosis, dysphagia, and cutaneous necrosis. Next slide. These are the screening recommendations he has made. Next, 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 next. So what are the risk factors with myositis? Developing or risk of increased malignancy is increasing age, male gender, dysphagia, cutaneous ulceration, and association of TIF1. What are the protective factors? Polymyositis, clinically hemopathic dermatomyositis, high muscle enzymes, associated Raynaud's, ILD, anti-G1, and anti-EJ are protective against cancer. Next. And these are the cancer screening tests he has advised. CT of thorax, abdomen, pelvis, PET CT, tumor markers, endoscopy, and whole body MRI. Next. Next. Scleroderma. There is increased chance of malignancy in scleroderma too, especially lung, hematological, liver, and esophageal. Other risk factors like old age, male sex, smoking, and diffuse cutaneous involvement, and association with anti-RNA polymerase 3. Next. 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 Primary Sjogren's and association with cancer. There is increased chance of hematological malignancy and also solid organs like thyroid. Next. How do you predict, if you see a case of Sjogren's, when do you predict malignancy chances? Whenever you see vasculitis, especially cutaneous vasculitis, associated glomerulonephritis, parotid and parotid gland enlargement and lymphadenopathy, low complements and cryoglobulins, and the focus score of more than 5 or 6 is associated with increased chance of malignancy in Sjogren's. Next. 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 Next talk by Dr. Johnstone, IgG4 related disease. Next. Next. So it's like earlier we discussed, it can mimic like GPA histologically. Next. Next. So it affects all the vessels in our body. Here you can see cutaneous vasculitis. Previous slide. You can see major vessel involvement aortitis. Next. Previous slide. Next. Next. Here you can see obliterative phlebitis. Next. Next. Here aortitis and medium vessel involvement here. So it is affecting all the vessels. Phlebitis in the involved organs. Next. And you can see here medial vessel involvement, coronary vessels involvement here. So next. And coronary artery aneurysms here. Next. So he says it's a variable vessel disease involving the veins and all 3 types of vessels. So it's a variable vessel disease. Other mimickers are Behçet's and Cogan's. Next. Whenever you see a case of scleroderma, you have to think of these mimickers whenever you see a skin thickening in your cases. Mostly we see lipodermatosclerosis and sometimes eosinophilic fasciitis. Also, you can think of drug-induced. Next. There's one talk on when do you stop DMARDs before vaccination, 4 weeks before and 4 weeks after with conventional DMARDs. With biologic DMARDs, just 1 dose interval. Next. Do you have time? So, Chairperson, do you have time, sir? Do you have time?
Time management is done from there.
5 more minutes. This is interesting talk.
Okay.
Diagnosis and management of systemic autoimmune disease.
You have 2 minutes.
Okay, sir. But Dan Kastner, next slide. So what I learned from his talk is all autoinflammatory diseases are of innate immunity. All autoimmune diseases, what we see, come from adaptive immunity, whereas autoinflammatory diseases from innate immunity. Next. 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 Familial Mediterranean fever, classically 1 to 3 days attacks of fever, sinusitis, arthritis, rash. Ethnic groups involved: Jewish, Turkish, Italian, Arabs. Childhood onset, mutation MEFV mutation. Colcin is the treatment of choice. When it is not effective, now FDA has approved canakinumab in FMF. Traps. Next. There you saw 1 to 3 days of attacks. Here the attacks last for 4 to 6 weeks, so longer duration. Attacks of fever, sinusitis, arthritis, rash, migratory rash, periorbital edema, associated with renal amyloid, childhood onset, mutation in TNF, RSF1A, and canakinumab approved by FDA. It is autosomal dominant inheritance. Next. Next. Previous slide. Hyperimmunoglobulin D hits on, but he says better to call it as mevalonate kinase deficiency. He thinks this is the appropriate term. Here, the duration of that illness is 3 to 7 days, recurrent febrile episodes with abdominal pain, arthralgia or arthritis, rash, adenopathy, after ulcers, usually onset within the first year. Next. Next. CAPS. Next. 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 So there are 3 types of disease we see in CAPS due to NLRP3 mutation, and luckily in developed countries they have these IL-1 inhibitors available, anakinra, rilnacept, canakinumab.
I think I request you to wind up now.
Yeah. So, yeah, we have done, sir. So these are FDA approved molecules for periodic fever syndrome. Next. 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 So this is one of the important one, data too. So he says the ADA levels, they correlate with the manifestations of the phenotype. If it is a mild to moderate deficiency, vasculitis. If it is severe deficiency, they develop pure red cell aplasia and bone marrow failure. Thank you.
Thanks so much. You can join here. I think my colleague Sanjeev will take up the case. Dr. Sanjeev Kapoor from Delhi.
Thank you, Sakir, for excellent disposition of ACR, and it is an endless topic because it is a huge, immense knowledge has been gained, and you have covered both the clinical arm as well as the bedside arm. So, I mean, it is fruitful that we can ask 2 questions only because we are running a little late, but if 2 burning questions are there, you can take it up. So we have seen in the ACR that, I mean, one is the Boolean definition for remission has been changed a little bit, and now there is a they are along for patient global to be 2, and as well as a new classification criteria for APLA has come, in which they are considering the microvascular and macrovascular pathologies, including the renal pathology, to be included in the clinical arm rather than the what used to be, and thrombocytopenia has to also be taken into account. So these are the major events which has changed, and use of steroid, as we have seen in the EULAR classification also, that they are not recommending that, guidelines that corticosteroids should be used in rheumatoid arthritis when we are using JAK inhibitors or TNF-alpha blockers. So, thank you very much.
So one slide I missed here about VEXAS. One important point he mentioned is all autoinflammatory syndromes, they're all childhood onset, whereas VEXAS is adult onset. That's important point. So usually starts after the age of 40, and most of them are men so far.
So we have to learn that.
Yeah. Sir? Yeah, I can send you, sir. I can send you.
It's available in the net also, but he can also
actually
send.
whole, you're talking about ACR, sir. No, if the same one I can give you, but ACR is available online. What he says.
He's saying that you can provide your.
Okay, sir. Yeah, it's my iPad is just here only.
I think we have to call it a day, because GBM is here in the same hall, I believe. So I think it is already 6:40. So I think we thank you so much for all the speakers, and
Thank you very much,
thanks.
sir.
Okay.